Hello, and thank you for joining us today. We have a few housekeeping items before we start today's program. I'm Andrea Jensen. I am the Interim Director of Education for Allergy and Asthma Network. All participants will be on mute for the webinar. We will be recording today's webinar, and it will be posted on our website within a few days, so you can listen to it again or feel free to share it with one of your colleagues. You can go to our website at allergyasthmanetwork.org, scroll all the way down to the bottom of the page, and then you will find our recorded webinars and any upcoming webinars. The webinar will be 1 hour, and that includes time for questions. We will take those questions at the end of the webinar, but you can put them in the Q&A at any time. We have someone that is monitoring the chat, so if you have questions or need any help, she's there to help you. We will get to as many questions as we can before we conclude today's webinar. We do not offer CEUs for this particular webinar, but we do have a certificate of attendance. You may have noticed that we are using a different platform this year. So instead of being able to download the certificate during the webinar, you will receive an email within a few days after the webinar with resources about COPD and any of the programs that we'll be talking about today, and a link to download your certificate. We will now begin today's webinar. Did you know that COPD is the 6th leading cause of death in the U.S.? Today's webinar will discuss Learn More, Breathe Better, a program from the National Heart, Lung, and Blood Institute, NHLBI, of the National Institutes of Health. NHLBI's Dr. Mihaela Stefan will present key facts and the latest research on COPD. Today, it's my pleasure to introduce her. Dr. Mihaela Stefan, MD, PhD, is a program officer with the Division of Lung Diseases at the National Heart, Lung, and Blood Institute of the National Institutes of Health. Prior to that role, she was the clinician investigator, Associate Professor of Medicine at University of Massachusetts Medical School, Bay State, and the Associate Director of Implementation Science at UMMS Bay State's Institute for Healthcare Delivery and Population Science. Thank you for being with us today, Dr. Stefan. We look forward to you sharing your unique perspective to treating those with respiratory infections.
All right. Hello, everyone. I am very sorry, but my camera is not working. The technology always gives us some challenges, so you'll see only my picture. Thank you for participating today. I hope that this presentation will be informative, and I'm looking forward to answer some of your questions. So we'll start with some quick facts. COPD stands for chronic obstructive pulmonary disease. Chronic means that is a long-term condition, and obstructive means that there is chronic inflammation which causes obstructed airflow from the lung. As Andrea said, but depending on the year and the statistics, COPD is the 4th or 6th leading cause of death in our country and is responsible of nearly 150,000 deaths per year. More than 16 million of people have been diagnosed with COPD, but unfortunately, there are many more who have the disease but do not know it. COPD affects 1 in 8 Americans, age 45 and older. And something that I'll say several times during this presentation is that although there is no cure yet for COPD, it can be prevented and it can be treated. So before defining COPD, I want to briefly explain the physiology of the normal lungs. The air comes in through your nose and mouth, move through the big pipe, which is the trachea, and down into the lungs. Air moves farther into your lungs through the bronchial tubes. The air ends up in some air sacs at the end of these airways, and these sacs are called alveoli. In these air sacs, oxygen from the air you breathe is absorbed into the blood. The oxygen is then carried in the blood to all parts of your body to help your body function. And the carbon dioxide, which is a toxin, is released from your blood and breathed out. COPD refers to a group of diseases that cause airflow blockage and breathing-related problems. The other way. COPD includes two main conditions, the chronic bronchitis and the emphysema. The chronic bronchitis occur when the bronchial tubes are irritated and swollen, and they produce excess mucus. And you can see in this graph that the normal tube has a larger diameter than the one in chronic bronchitis. This excess of mucus causes coughing and shortness of breath. Lining the bronchial tubes of the lungs are some hair-like fibers, which are called cilia, and they help to move the mucus up the bronchial tubes so it can be coughed out. In chronic bronchitis, the tubes lose their cilia, and this makes it hard to cough up mucus out of the lungs. Smoking, even just a little, keeps the cilia from working normally. The other condition is emphysema, and the damage to the air sacs causes emphysema. The walls inside the alveoli sacs disappear, making the many small sacs become larger sacs. And these larger sacs do not transfer oxygen from the air to the blood as well. Also, when the alveoli are damaged, the lungs become stretched out and lose their elasticity. The air becomes saggy and the air trapped in the lungs. And this is why there is this feeling that you cannot take a deep breath if you have COPD. Chronic bronchitis and emphysema overlap in the same patient. So it's not that a patient will have only chronic bronchitis and emphysema, they can have both. A few words about asthma and COPD. Some people who have asthma can also develop COPD, especially if they smoke and when they are older. Asthma is a chronic lung disease that inflames and tightens the airway. And just to remind you that asthma has variable airflow obstruction. The symptoms vary widely from day to day. They are worse at night and in the early morning. People with asthma have frequently allergy, rhinitis, and eczema. And asthma occurs frequently in children, and people have family history of asthma. The asthma treatment usually can reverse the inflammation and the narrowing of the airways. However, in the presence of COPD, much of this reversibility is lost, and we'll talk a little bit more of what's happening in COPD. There is something also that we call asthma COPD overlap syndrome, or ACOS. And ACOS is diagnosed when you have symptoms of both asthma and COPD. ACOS is not really a separate disease, but it's rather a way for doctors to recognize that there is a mix of symptoms and select the most appropriate treatment plan. We think of ACOS in a patient who has persistent airflow limitation. The patient usually is older than 40, and they have a history of asthma, or when they are giving a bronchodilator, there is a large reversibility, which does not happen in COPD. We know that people with the diagnosis of ACOS tend to have more symptoms than people with either asthma or COPD alone. This syndrome was defined not a very long time ago, and we don't understand well the mechanism of the disease, and as such, we don't have good treatments. So this is why we need future research to understand this condition. Now, going back to the COPD, we'll talk about the causes and risk factors. And in a nutshell, the most important are history of smoking, long-term exposure to lung irritants, and a rare genetic condition, which is called alpha-1 antitrypsin deficiency. Smoking is the #1 cause of COPD in our country and is responsible for 8 out of 10 COPD deaths. 75% of patients with COPD have a history of smoking. Smokers inhale more than 4,000 chemicals, and more than 40 of these cause cancer. When smoke enters the lung, it causes irritation and inflammation, and the body sends white blood cells to that areas. And these white blood cells release strong enzymes that damage the lung tissue. Um, However, only 1 in 5 smokers will get significant COPD. So researchers are trying to find out why some smokers get COPD and others don't. So what protects some smokers from getting COPD? I also want to add that 1 out of 4 people who have COPD have never smoked. In addition to the smoking, there are few other reasons to get COPD. One is the long-term exposure to lung irritants, secondhand smoke, certain chemicals such as ammonia or asbest, dust or fumes from the environment or workplace. And there is a genetic disease, which means that it's passed from parents to their children. And this is called alpha-1 antitrypsin or AAT deficiency. And as many as 100,000 Americans have this condition. People with alpha-1 deficiency have a much lower than normal level of this protein, blood protein. And this protein protects the lungs from irritation caused by infection or breathing in toxin. You can find out if you have alpha-1 through a simple blood test. And in fact, the guidelines recommend that everyone with COPD should be tested for alpha-1. This is very important because there is a specific treatment for alpha-1 deficiency that can slow the progression of COPD. Who is at higher risk for COPD? Interesting, women are at higher risk than men. And on the right side in green, you see that of those affected, so of those with COPD, 56% are women and 44% are men. People who are older, over 65, those with a less than a high school education, current and former smokers, and you see also on the right that by smoking history, 38% of patients with COPD are current smoker and 37% are former smoker. People with history of asthma. Also, COPD is more frequent in rural areas than in urban areas. And in some areas in United States, the Southeast and areas of the Mississippi and Ohio River Valley. When we think by race, 9% of American Indians and Alaska Natives have COPD, compared with 5% of whites, 5% of non-Hispanic Blacks, and 2% in Hispanic and 1% in Asian. So we see that there is a difference by race. How to diagnose COPD is based on signs and symptoms, and I'll discuss this in a following slide. Personal and medical history, what we just discussed, like risk factors, smoking, history, exposure to lung irritants, secondhand smoke, air pollution, chemical fumes or dust, a physical exam, and tests such as spirometry, chest X-ray, chest CT scan, and arterial blood gas. Symptoms of COPD can be different for each person, but common symptoms are constant coughing. Sometimes we call it smoker cough, shortness of breath while doing everyday activities, inability to breathe easily. So taking a deep breath is difficult. Excessive mucus production, which is coughed up as sputum, and wheezing. You may hear from some who have asthma or COPD, sounds like, so that's wheezing. It is easy to think of shortness of breath and coughing as a normal part of aging, but this could be sign of COPD. And millions of people do not realize they have COPD and are undiagnosed and untreated. COPD can progress for years without noticeable shortness of breath. That is why it is important to talk with your healthcare provider as soon as you notice even small symptoms. And you see on the right that the top diagnosis barriers that healthcare providers encounter, and this is of course valid for COPD, that 44% of patients do not report their symptoms. They think that this is part of my smoking, is the coughing that is the smoker cough, or again, that shortness of breath is just because I got older. 35% of patients go to the doctor, but they have more immediate health issue and they don't bring this up, or the patient does not fully report smoking history. COPD is usually diagnosed through lung function tests such as spirometry. And spirometry is a quick, painless, and simple breathing test that checks how well your lungs are working. It measures the amount of air a person can blow out of the lungs and how fast they can blow it out. After the first measurements are taken, a bronchodilator medication is given and the pulmonary function tests are measured again. So this is what we were discussing earlier about asthma, the difference between the asthma and COPD. With a bronchodilator in asthma, there is a large reversibility, while in COPD is minimal. Um, your doctor may order additional tests to get a more complete picture of how your lungs are functioning, but spirometry is extremely important for the diagnosis of COPD, to assess how severe COPD is, but also it can find out whether other conditions such as asthma or heart failure are causing the symptoms. Now we are going to move to treatment of COPD, and I'm going to say that again, there is no cure yet for COPD, but treatments are available to help individuals live better with this condition, so don't be discouraged if you have COPD. Lifestyle changes and treatments can greatly improve a patient's quality of life and allow them to stay more active and slow the progression of the disease. Now, lifestyle changes are hard. They are harder than taking pills. The most important are quit smoking, and I'll talk about this in the next slide. Avoiding pollutants, so having efficient ventilation, non-polluting cooking stoves are recommended. Also, you can check the air quality on a weather app and decide if maybe there are days when it's more appropriate to stay indoors. Exercising is important, and we'll talk about pulmonary rehab and how this can help you become more active. Keeping your weight in check, visiting your provider regularly and taking your prescribed medication is important, staying current with your vaccination. And I cannot emphasize more how significant for the patient is to have support for family and friends. And we will talk about this, that we have a toolkit for the caregivers and how they can help their loved one with COPD. Quitting smoking. So if you are currently a smoker, the most important thing you can do to slow the progression of your COPD is to quit smoking. You should talk with your doctor about programs and products that can help you quit. Um, we have a national quit line. You can call it at 1-800-QUIT-NOW to connect directly to your state quit line and get access to free local resources. There is another government site, smokefree.gov, And there are many options available to help you quit smoking. And these options include gums, patches, and prescription medicine, among others. If you have trouble quitting smoking on your own, consider also joining a support group and ask your family members and friends to support you in your efforts to quit. While you are unlikely to return lung function to normal after quitting smoking, you will slow the progression of your COPD. And if you have already quit smoking, congratulations. Now, we'll talk about the treatment of COPD, which can include medications, oxygen therapy, pulmonary rehab, surgery, lung transplant, and palliative care. And on some other slides, I will talk about pulmonary rehab and palliative care. But few words about medications. There is a variety of medicine which are used to treat COPD, and there is no best medicine for all people. Each person's COPD is different, and your doctor and healthcare team will work with you to set up the best plan to address your symptoms and needs. In regards to the medication, there are two most important classes. If you have COPD, you are well aware of those. One is bronchodilators class. They relax the muscles around the airways and make breathing easier. Most bronchodilators are often delivered through an inhaler or can be nebulized. And inhalers operate in different ways. So make sure to ask your healthcare team to show you how your specific inhaler works. And also make sure that you are doing it correct. So ask your care team to see that the way you are doing it is correct. The other class is anti-inflammatory medications, and decreasing inflammation leads to less swelling and mucus production in the airway, and that makes it easier to breathe. These medications are known as corticosteroids or steroids. Sometimes with COPD, you require extra or supplemental oxygen, and there are several devices used to deliver oxygen. Your healthcare provider will help you choose the equipment that works best for you. In regards to surgery, the surgery takes care of the emphysema component of COPD. So when the air sacs are destroyed, and maybe they are together and kind of um, build a larger sac, which is we call a bulla. So that may be addressed through surgery. But surgery is not for everyone. The other option is transplantation, and in appropriately selected patients with severe COPD, lung transplantation has been shown to improve quality of life. Surgery and lung transplant are options that you can bring up with your pulmonologist, with your lung doctor, and discuss if these are therapies that could help you. So now something about pulmonary rehab. If you or someone you love suffers from a chronic lung disease like COPD, there is hope for rebuilding strength and enjoying a fuller and more active life. And pulmonary rehabilitation can help you with this. It is a personalized treatment program that teaches COPD management strategies to improve quality of life. Years ago, before I became interested in the pulmonary field and especially in pulmonary rehab, I really thought that pulmonary rehab is mainly about exercise training. But this is not the case. This program includes, in addition to exercise training, which is tailored toward your needs and capabilities, it includes breathing techniques such as yoga or mindfulness, instruction in finding energy-saving ways to do everyday tasks. It can help to stop smoking. Also, one component is psychological counseling for emotional problem, because again, COPD is a serious illness and you might need this type of help, and nutritional counseling. Pulmonary rehab may help people with chronic breathing problems to live and breathe better. And studies have shown that 2 in 3 people who participate in PR report positive outcomes like reducing COPD symptoms, increasing physical activity, improving daily life function, and emotional health. Pulmonary rehab classes are offered in group setting, so you get the chance to meet others with your condition, which provides an opportunity to give and receive peer support. And the skills and knowledge you learn in the program will help you feel better and manage your chronic lung disease. Exercising your lungs and your muscle helps you be more active, so you can do the things you enjoy. PR may even decrease the need for hospital visits. The bad news is only very few people with COPD participate in PR. Some do not know, they get referred, but they don't understand, or say different, maybe their providers do not emphasize enough how important pulmonary rehab is. Other barriers to pulmonary rehab include poor access to PR facilities and capacity constraint at those facilities. Now, a variety of novel models of PR have been tested in small clinical studies, including individual and virtual group, with real-time remote supervision and monitoring, telephone-based coaching model, and even light touch models using apps and website. Now, by necessity, the uptake of this remotely delivered PR in clinical practice has accelerated over the last 2 years with the pandemic. And results from small studies suggest that tele or video rehabilitation is safe and has similar benefits to those of center-based PR. However, we need rigorous studies and robust quality assurance and quality control to ensure that remote PR models deliver the excellent outcomes for which center-based PR is known. And on this slide, you see that um, one of the studies that is supported by the NHLBI is a large and rigorous trial which is testing video telehealth PR to understand exactly if it confers similar benefits to center-based rehab. Next to palliative care. Palliative care is called also supportive care, is a specialty in medicine which is focused on treating the symptoms, pain, and stress that accompany serious illness like COPD. It is available to you from the moment you are diagnosed and through the entire course of your illness. Palliative care improves quality of life by relieving overwhelming physical and emotional symptoms and improving communication with your healthcare providers. A palliative care specialist include a team of doctors, nurses, and social workers, and they will make sure that your specific expectations are matched with the care you receive for COPD. Palliative care teams can help you and your family understand your treatment options and goals, plan for the future, and offer practical advice about talking to loved one. They also help with making difficult decisions. I want to emphasize that palliative care and hospice are not the same. I know that many people think that palliative care is really end of life, and that is not the case. Hospice is for what we call the last 6 months of life, but palliative care is another layer of support that you can get even earlier in your disease. A few words about COPD research. Research help us understand the causes of COPD, the mechanism for its development and how it is best treated. At least half of those with COPD and their families are interested in getting more information about COPD treatment and especially about advancing treatment and ongoing research. To kind of illustrate the importance of COPD research, I will present two studies. They are called Spiromics, and this stands for Subpopulation and Intermediate Outcome Measures in COPD. And this study supports the collection and analysis of markers in the blood, genetic markers, and clinical data for participants with COPD for the purpose of identifying groups of people with COPD with same characteristics and such better targeting treatment. It enrolled almost 3,000 patients and followed them for over 3 years. So in the first study, they found that more than half of people with a history of smoking and preserved lung function on spirometry had significant respiratory symptoms. Many of these individuals were prescribed COPD drugs, even though they did not have lung obstruction on spirometry, they did not have COPD. So the follow-up study was to understand, do their symptoms improve if they are treated with these drugs, with bronchodilators? And unfortunately, this study showed that, in fact, the symptoms did not improve. So getting a medication that doesn't help you, at the end, you'll get mainly the adverse event. So we need more research to understand how appropriately treat various group of patients in an early stage before the damage of the lung is serious. But just to understand, that's why we need research, because maybe logically would have been to give this patient the treatment, but in the end, the treatment did not really help. Next, about COVID-19 and COPD. Studies didn't show any significant difference in the rate of infection between those with COPD and those without. However, people with COPD had higher rates of hospitalization, ICU admission, and death compared with non-COPD. Patients with COPD should get vaccinated and get the booster against COVID-19. And of course, patients with COPD should get the flu vaccine and pneumococcal vaccine and use their prescribed inhaler as they did prior to the pandemic. What about the awareness of COPD? Although it increased in the past 10 years, 1/4, so 1 in 4 adults in the US have never heard about COPD. And 3 out of 10 people with COPD symptoms go undiagnosed and untreated. So concern about the growing incidence of COPD and of course the millions of dollars spent on COPD related care, members of the Congressional COPD Caucus urged the National Institute of Health and the Center for Disease Control to craft a comprehensive federal plan to tackle the disease. So developed at the request of Congress and with input from the broad COPD community, in 2017, the COPD National Action Plan was published. This is the first ever blueprint for a multifaceted, unified fight against this disease. And it provides a comprehensive framework for action by those affected by the disease and those who care about reducing its burden. And this action plan is in fact a living document, so it's not stuck in time. It's subject to revision as new needs and opportunities to minimize the burden of COPD arise. And you can find it at copd.nih.gov. Here are the 5 main goals of the COPD National Action Plan. The first one is to empower people with COPD, their families and caregivers to recognize and reduce the burden of COPD. The second goal is to improve the prevention, diagnosis, treatment, and management of COPD by improving the quality of care delivered across the healthcare continuum. The third goal is to collect, analyze, report, and disseminate COPD-related public health data that drive changes and track progress. The fourth goal is to increase and sustain research to better understand the prevention, pathogenesis, diagnosis, treatment, and management of COPD. And lastly, the fifth goal is to translate national policy, educational and program recommendation into research and public healthcare action. To achieve the goals of the COPD National Action Plan, it is important that all members of COPD community get involved. And the plan you see has specific action for the various groups which must be involved. Healthcare professional, policymaker, researchers, you, patients and caregivers, advocates and nonprofit. So if you are a patient, the goal 1 and 5 are most relevant. If you are a healthcare professional, goals 1, 2, and 5 are most pertinent. A community action tool was developed to document the progress the COPD community has made toward implementing the goals and objectives in the COPD National Action Plan. Real-time information from the COPD community about activities by goals, type of organization reporting, audience served, and type of activity is recorded. You see that there are several feature programs in the Community Action Tool, including the Allergy and Asthma Network, the COPD Foundation, the Learn More, Breathe Better program from the NIH, American Lung Association, and many more. The Learn More, Breathe Better program, I want to spend just a few minutes on this, is a national health education program that aims to bring greater visibility to lung health by translating research for public and professional educational programs. I encourage you to go online and access this program. It provides a lot of free resources about symptoms, diagnosis, treatment, and management for patients and caregivers. It has animated videos, fact sheet, infographic, and social media resources, and everything is written for patient in such a way that you will understand. There are also resources for healthcare providers. There is a provider digital toolkit. There are podcasts which have CMEs and teaching tools and patient hands-out. Additional COPD resources, we talk about Learn More, Breathe Better website at copd.nhlbi.nih.gov, the COPD National Action Plan. I mentioned that we have a COPD caregiver toolkit, which I encourage you to access if you have a loved one with COPD. And I want to end saying that, again, that COPD is currently an incurable disease, that COPD is preventable and treatable. There remain many unknowns about the natural history of lung function decline and the development of COPD. And this is why research at NIH and other foundations are so important, hoping that we'll find a cure in the future and also better treatment for patients with COPD. And that's what I have.
Thank you, Dr. Stefan. I was scribbling notes the entire time you were talking. I learned so much from this presentation. And I think one of the biggest takeaways, and from some people also in the chat, is that there's so much hope for people that have COPD. That is a great takeaway message. And then all of the resources you have listed, such as pulmonary rehabilitation and palliative care. So this has been a fantastic presentation, and we have a few questions here in the chat. And so I will go through some of those. So our first is, and this could be a tricky one, how can I help my spouse stop smoking? That's easier said than done, correct?
Yeah, that's a great question. I think what I would recommend is that the first step is to understand that people who smoke become addicted to nicotine. This is a drug that is found in tobacco. So this can make it hard to quit smoking. So we need to make sure that we are not blaming on the person who is smoking. This is an addiction, right?
Yes.
To be able to help you need to be informed about all the resources for smoking cessation, because quitting smoking is hard. It often takes multiple attempts before quitting for good. So don't be discouraged if your loved one tried and then started again smoking. There are many resources to help you and your spouse. You can talk to a quit smoking counselor. This counselor can be individual or in group. I mentioned the National Quit Line. There are several websites. We recommend the one which is the smokefree.gov. There are free texting program or mobile apps. So people sometimes say, oh, I'm going to quit cold turkey. I can do it. Some can, but most cannot. We know that there are many options available to help a person quit smoking, and we discussed the gums, patches, and there are prescription medicine. So you as a caregiver would prompt your spouse to take them. And remember, even if they tried before, the key to success is to keep trying and not give up. After all, more than half of US adults who smoke have quit. I want to take just 2, 3 minutes. I'm sure that this is a question in many people who smoke or have someone who smoke mind, and it's about the e-cigarettes. Are they useful for quitting smoking? And we we don't have a firm answer, but we know that at this time, e-cigarettes are not approved by the FDA to help people quit smoking. For those of you who don't know exactly, an e-cigarette is a battery-powered device that produces an inhaled vapor. And it does so by heating a liquid that usually contains nicotines. And e-cigarettes vapor is not just water vapor. They may contain chemicals, and we do not know enough about their effects. You may have heard that in 2020, there was an outbreak of diseases related to e-cigarettes. And there are a few studies which show that among those who use e-cigarettes to quit smoking, in fact, after a while, they still smoke and use e-cigarettes. So this would be something that we will not recommend, but we will recommend some of the other options which we know that will work.
Thank you. Thank you. That was a great expansion on that question there, because we do get that question quite a bit where people do ask about vaping. Another question that we have in the box. Oh, and I wanted to give you one fun little comment before I go to the next question. Someone said, singing is great lung exercise.
Yes, that's a great point. And on COPD Foundation, in fact, they have an exercise with the harmonica. I'm not sure if I pronounce it correct
Yes.
with my English. Okay, so there is a harmonica exercise, and there are some studies which show, so you are absolutely right with the singing and using this type of device to help. It helps you kind of take a deep breath and train your breathing. So thank you for that comment.
I had to laugh when I read that, because I thought I'm one of those that will only sing in my car or in the shower, but I'm sure there are better singers out there. Our next question is, why do more women get COPD than men?
Yeah. So in the last 2 decades, we know that the prevalence of the frequency of COPD increased among women. And we think it's due in part to increased tobacco use among women worldwide and exposure to biomass fuels. Yet in general, women smoke less than men, suggesting that they may be more susceptible to developing COPD in response to cigarette smoke exposure than men and to other pollutants. Overall, women smokers are about 50% more likely to develop COPD than men. And the exact reason for susceptibility for women is not known. What we also know that women are more likely to develop COPD of the small tubes, of the small airways, not emphysema. And one idea is that the airway of females are relatively smaller than those of males for the same lung volume. So maybe there is a greater concentration of tobacco smoke in those areas. Another hypothesis, but that's not proved at all, is just maybe the metabolism of cigarette smoke may differ in women. So the bottom line is we do not know for sure, and there are several studies that are trying to understand that. What we know is that somehow women are more susceptible to smoking and pollutants in general.
Okay, thank you. And I do like your comment there that women are different from men. We're not small men. We do
Right.
have different biology and mechanics and everything else. So another question we have, if I am diagnosed with COPD, does that mean I will be stuck hauling around an oxygen tank?
Yeah, that's thank you for the question. Now, finding out that you need supplemental oxygen um, can make you scared and frustrated. And I know I had a friend who had to carry the oxygen around, and her feeling was initially that people view as handicapped. You might think that it will be a hassle to be connected to an oxygen the tank, and that you may really think all the plans you had around having the oxygen. And if you are thinking or feeling this way, remember that oxygen therapy can help you feel less tired and less out of breath. And you may be able to do more than you could before. And it may even help you live longer. So that's the first point that I want to make, that yes, there will be some downsides, but this is something that might help you with the quality of life and then long term. If you found that you need oxygen, you need to talk with your doctor and not only accept whatever they write, but to ask what type of delivery system and discuss is best for you, and discussing about your needs, not only at home, but how active you generally are, and how can you provide to have this oxygen if you are exerting yourself. So just quickly, I want to explain how this oxygen, the types of oxygen, there are two types, gaseous and liquid, and systems were kind of different, and there are pros and cons for each system. I think many people think that or saw that in the past, many oxygen users were given like a home concentrator and a tank for going out. And the problem with this arrangement was that the patient had to pull the tank on a cart when going outside their home. And inside the home, a user could move only as far as the tubing would go. However, the technology advanced and we have newer type of oxygen system. And in this newer system, the oxygen is produced in the home by a concentrator and is stored in a tank which is refillable. And these tanks are small and light, and you can easily carry them on a shoulder case or a backpack. The length of time these smaller tanks last varies on how much oxygen you need. And in fact, we were talking with Andrea just before this session that someone asked her about continuous and pulse oxygen. And there are systems right now more advanced that some of them just give oxygen continuously, but some of them give the oxygen only when you breathe in, and that allows the oxygen that you carry to be there for longer time. So you are you can go out for longer period of time. So the system also help you move around easier inside and outside your home, and you don't have to rely on someone who need to replace tanks when you need them. So it puts you in control of filling your own tanks, and you even can transfer, you can move out this entire system if you decide to relocate to a summer home. The other oxygen modality is the liquid oxygen, which is good for those with higher needs of oxygen. And it's stored in a home reservoir, but that needs to be filled on a regular basis. But you can still use the reservoir to fill smaller containers. So bottom line is that if you need the oxygen, you should use it. You should be reevaluated, especially after the first time you've been put on oxygen in about 60 to 90 days. You should go to your primary care to reevaluate. Do you still need that? Because maybe you started it just because you were in the hospital and you had an infection in your lungs, and maybe you don't need it anymore. And if you need it, just make sure that you have the system that will help you be as independent as you can, but remembering that this helps your quality of life on long-term prognosis.
Thank you. Thank you. That was a great answer to the question. I really like how you focused on if you use the oxygen, if you need it, and it really will help you feel better and make you to help you to be able to do more things with your life and have a better quality of life. So thank you. Thank you.
Yeah, no, that's an
Next question.
important thing for
Yes.
everyone who has it. Yeah.
Yes, absolutely. Our next question is pulmonary rehabilitation only for COPD? I've heard that people with asthma and long COVID have needed it.
Yeah, so pulmonary rehab, as we discussed, is this supervised education and exercise, which is designed to help people with chronic lung diseases. So any person with chronic lung disease might benefit from pulmonary rehab. COPD, we know the most about COPD, pulmonary rehab in COPD, but those with lung cancer surgery, asthma, pulmonary hypertension, and more recently, pulmonary rehab is tested for long COVID. And we know that although pulmonary rehab will not cure your lung disease, but you may notice fewer breathing problem, more strength, and improve quality of life. So in summary, yes, it's not only for people with COPD, but also other conditions. So make sure that if you have COPD or this other condition, ask your healthcare team if pulmonary rehab is appropriate for you.
Thank you. You know, I happen to be one of those people with asthma and long COVID, and I didn't think pulmonary rehab was for me. I thought it was just for people that had COPD, and it made a big difference in my improvement. So just going to throw that out there.
Yeah.
Our next question is, I thought palliative care was only for people who were dying. And so most
Okay.
people think that's probably within a few months. So I think that's probably what they're referring to.
Right. I know. I have a disclosure. So I was a palliative care doctor. So I'd say that um, I kind of know a little bit more about this. I want to make sure that we make this distinction between palliative care and hospice, because people wrongly believe that it's only for people who are close to dying. Palliative care, as I said, is called also supportive care and is key in managing COPD. And it's focused on helping you achieve the best quality of life and is appropriate for all people living with COPD, regardless of stage or prognosis. It's just think of the palliative care like an extra layer of support that focuses on your needs and provide relief for symptoms and stress of the disease. because it can help you in several ways, including therapies to relieve the discomfort of shortness of breath or anxiety, education about lifestyle changes during COPD, medication and disease management. And the palliative care team works in partnership with your own doctor to provide support for you and your family. Thinking of the hospice is indeed we say that is indicated for those who we think they have 6 months or less of living. But COPD is a chronic condition, and patients can be in the hospital and really sick on mechanical vent and then live another several years. So it's hard to predict. And it's not that if you go on hospice, that means that, yes, the end is near. That's not the case. Unfortunately, people access hospice very late, even for those who have a very advanced disease. And it's just in the last 2 weeks of life, and they lose all this additional support because the hospice has not only this group of doctors and nurses, which are 24 hours on call, but they have also volunteers. So it's a lot of support that helps the patient and the family to go through difficult times.
Thank you. Thank you for talking a little bit more about that. We have time for about 3 more questions. So one is, my wife was diagnosed with COPD and I am her main caretaker. I do not know where to go for help.
Yeah, that's hard, and caring for someone with COPD is complicated. And I would say that the first step is to understand more about the condition. It is good to know what might be a symptom of COPD and what might be a symptom of a different condition. People with COPD, they take a number of medications. So it's important to know what the medications are, when to use them, and how to take them so you can provide better care for your spouse. Now, I mentioned this before, but the National Institute of Health, Respiratory Health Association, and Learn More, Breathe Better program developed the COPD caregivers toolkit to help the caregivers of people with COPD. And I will encourage you to go on this site and download all this information because they will be very helpful. The first step in my mind is that you need to understand this disease such that you can be of help and support them in their quest for to quit smoking, or how to take their medication, or just to understand what to do if they have symptoms. Developing a plan and thinking, we are going to the doctor and we have to have some questions written down to ask the doctors. So the finding this caregiver toolkit, I think will help you because it will standardize what you need to know and what you have to do.
That's a great resource. And in fact, when we send an email out in a couple of days after the webinar, we will include all these resources. So don't think you need to hurry and scribble these down. We will send the links out to you. And that's a great option for people that just don't know what they don't know. So great resource. We have another one, and this is probably going to be our last question. We might have time for one more. If I have COPD, should I get vaccines? Should I get the COVID-19 vaccine?
Oh, absolutely. Yes, I have no doubts about this. So you should get the booster. So the bivalent, so the COPD vaccine and the booster are indicated because this booster, which has the two variants, again, is the word the two variants is indicated for those with a condition, so those over 50 or with a serious condition like COPD. And we know that those who were vaccinated were less likely to be hospitalized and die. I can tell you from my personal experience, I joined NIH in March, but before that I was a hospitalist, and I worked through all this time period when COVID was there. And we even, of course, we know this more for studies, but even in the hospital, we saw that there was a difference in the severity of illness between those who were vaccinated and not. In addition to the COVID vaccine, of course, you should get the flu vaccine. Hopefully, you got it this year, and also the pneumococcal vaccines.
Excellent. Thank you. Thank you. And our last question, someone asks, is it normal or can it happen that someone that's younger than 40 who has been a smoker, can they get COPD even at a younger age?
Yeah, so I was talking a little earlier about this disease, which is called alpha-1 antitrypsin. So for someone who was not a smoker, but the smoking will make it the disease to come quicker, um, someone with this condition is more likely to develop COPD at a young age, even in the absence of smoking, even in the absence of any other risk factors. So if you or someone you know were diagnosed with COPD at young age, make sure that they are tested for the alpha-1 antitrypsin. In fact, I want to emphasize again that the guidelines that we have right now is that anyone should be tested for alpha-1 antitrypsin deficiency. It's an easy test. It's a blood test. Your primary care can order it with your regular blood test. And it is important because it's not frequent, but we don't diagnose it enough. And if someone has it, we have a specific medication to slow the progression, which we don't have for the other COPD that is not alpha-1.
Thank you. Thank you. That was a great explanation on that. We did have some people asking earlier about alpha-1 and how do you get tested and if your insurance covers it. So thank you.
Yeah.
That kind of wrapped everything up in a nutshell. They can order it along with other blood tests. And as we know, every insurance company is different, so it depends on what they'll cover. If you can just go forward just one or two more slides. We do have a webinar. We do have a free 6-week COPD education program. This is through Allergy and Asthma Network. As I mentioned, it's free. We have that in English and Spanish, and there are incentives that are available for anyone that wants to participate in that. We will also include that link in the information we send out after the webinar. And then let's see, one more slide. This will be our webinar next week. Is it the environment or is it genetics? We will be able to offer CEUs for this particular webinar next week on Valentine's Day on the 14th. So look for that. You should have information to be able to register for that. Thank you. I cannot thank you enough, Dr. Stefan. I have learned so much from you and I have a whole page of notes. Thank you again for joining us. This is Andrea Jensen for the staff at Allergy and Asthma Network. Thank you for joining us as we work every day to breathe better together.
Thank you for inviting me.